Welcome to Evidence-Based Cardiology Talks. This is the deep dive where we really unpack the latest, most relevant publications in contemporary cardiology for you.
Great to be here. We're looking at a major report from the Lancet Commission.
Yeah, it's called Moving from Ischemia to Atheroma, and it really challenges the traditional approach.
It fundamentally asks us to rethink how we view heart disease. For years, the focus, as you know, has mostly been on ischemia.
Right, the heart muscle not getting enough blood, usually because of a blockage.
Exactly. Find the blockage, fix it, restore the flow. That's been the standard thinking.
Seems logical on the surface, like fix the plumbing problem, but the commission says that's, incomplete.
Yeah, it's missing the bigger picture. The core argument is that by the time someone actually feels symptoms of ischemia, like chest pain, the underlying disease, the atherosclerosis, has often been building up for a really long time, maybe decades.
So interventions at that point, while helpful, are kind of late in the game.
They can be life-saving, absolutely. But they might not be addressing the root cause systemically. And, coronary artery disease is still a massive global killer, despite everything we can do.
Which suggests the old approach isn't the whole story.
Precisely. It has limitations.
Okay, so this leads us to the Commission's big proposal. Shifting focus to atherosclerotic coronary artery disease, or ACAD. What does that mean in practical terms?
ACAD basically just means there's atheroma plaque in the coronary artery walls. Simple as that.
But the key is when it's there.
Exactly. This plaque can start building up way earlier than we used to think, often silently, long before it causes any major obstruction or ischemia. So ACAD covers the entire spectrum, from the very first fatty streak to advanced blockages.
So the big aha moment for you, the listener, is that waiting for symptoms like chest pain might mean you've missed the boat on early intervention. The real disease process starts much sooner.
That's the crucial insight.
Our mission today, then, is to unpack why this shift to thinking about ACAD is so vital. It's more than just changing the name, right?
Oh, absolutely. It's not semantics. It's about fundamentally changing how we approach detection, prevention, and management.
With potentially huge implications.
The Commission believes this shift could genuinely save millions of lives globally by catching and treating the underlying atherosclerosis much, much earlier.
Okay, let's dive deeper into why that old ischemia-focused model is considered flawed. We mentioned timing, but what else?
Well, a big one is the focus on fixing specific blockages, things like stents or bypass surgery.
Standard procedures.
Right. Very important in acute situations, no doubt.
Yeah.
But they are localized fixes. They don't stop the atherosclerosis from progressing elsewhere in the coronary arteries or even in other blood vessels.
It's like patching one rusty spot on a pipe, but ignoring the overall corrosion.
That's a good analogy. You're treating the symptom, the immediate blockage, but not necessarily the systemic disease process.
And the report points out that heart attacks often don't even stem from those really tight, flow-limiting blockages, do they?
That's another critical point. Many, maybe even most, heart attacks happen when a plaque ruptures or erodes suddenly.
A rupture.
Yeah, think of a plaque with a thin cap over a soft, lipid-rich core. If that cap breaks, bang, a clot forms very quickly, blocking the artery. And these vulnerable plaques might not even be causing severe narrowing beforehand.
Wow. So they can be dangerous even if they aren't causing day-to-day ischemia.
Exactly. So focusing only on the narrowings that limit flow misses these potentially dangerous but less obstructive plaques.
It really does sound like shifting from firefighting to fireproofing. Makes sense. And there's a cost element, too.
Yes. The Commission highlights the huge amount of resources, money, time, personnel spent managing late-stage ischemia and its complications.
Hospital stays, procedures, tests.
Right. And while necessary, perhaps we're missing opportunities for much more cost-effective interventions earlier on, focusing on prevention and slowing the plaque buildup itself.
Okay, so let's really unpack this ACAD concept. If it just means plaque is present, even tiny amounts, why is that such a game changer?
Because it shifts the goal. Instead of waiting for problems for ischemia, the priority becomes finding and managing risk factors early. It opens the door for screening, for genuine prevention, for early diagnosis, maybe even for reversing the process someday.
A cure, even.
That's the ultimate hope, though we're not there yet. But regression, slowing it down, preventing events that's achievable now if we shift focus.
And this idea that ACAD isn't just an old person's disease, it starts young.
Absolutely critical. The Commission emphasizes that the risk development starts incredibly early. We're talking utero influences, childhood, adolescence.
Yeah.
The process begins silently. decades before any clinical event might occur.
Which makes early detection and prevention absolutely paramount.
Yeah.
How does the ACAD framework change the prevention game?
The potential impact is just enormous. If we can effectively tackle the main drivers early on, smoking, high blood pressure, cholesterol, diet, inactivity.
The usual suspects.
The usual suspects, yes. If we address those effectively across the population, starting young, the reduction in ACAD burden could be dramatic.
They put some numbers on that, didn't they? Quite startling numbers.
They did. Their modeling suggests that eliminating those major known risk factors by 2050 could cut ACAD deaths by something like 82%.
82%, that's huge.
It translates to potentially 8.7 million lives saved annually worldwide. It's a mind-boggling potential benefit.
So how do we get there? What does early detection and prevention actually look like in this ACAD model?
Well, it means implementing targeted screening programs much more widely, identifying people at higher risk much earlier.
Before they have symptoms?
Exactly. Using risk scores, maybe imaging in some cases, to find early signs of atherosclerosis. Then you can intervene lifestyle changes, maybe medication to halt or slow things down before a major event happens.
Now, the Commission doesn't shy away from the fact that this isn't happening equally everywhere. There are big global disparities, right?
A crucial point. There's a massive gap between high-income countries and low-to-middle-income countries in prevention, diagnosis, and treatment access.
And that gap affects outcomes dramatically.
Absolutely. And the projections are worrying. They predict significant increases in ACAD death rates in lower middle and upper middle income countries in the coming decades.
Increases, while hopefully high-income countries continue to see decreases.
That's the forecast. Increases of maybe up to 19% in lower middle income countries by 2050. It highlights this huge need for global equity in tackling ACAD.
Okay, so focusing on early ACAD also means rethinking our emphasis on treating the late stages, the obstructive disease. What are the limitations there?
Well, imaging techniques have improved, sure. We can see blockages better now with things like CT angiography.
FETA.
Right. But the Commission points out that by the time we detect significant obstructive disease that way, the best window for prevention is often already closed. Our options are more limited then.
And those interventions like stents and bypass, we touched on this, they have their place, but they aren't a cure for the underlying disease.
Exactly. They treat a specific blockage. They can relieve symptoms, save lives in emergencies, but they don't stop the atherosclerosis elsewhere. They're necessary, but often palliative in the context of the whole disease process.
So it's crucial to distinguish. Ischemic heart disease is that late stage, often symptomatic manifestation. ACAD is the presence of the atheroma itself, potentially starting way earlier and silently.
That's the core distinction. Viewing ACAD as this lifelong continuum is key to a better long-term strategy.
This idea of a continuum, it sounds like we need a clearer way to define the stages.
Yes, the Commission calls for a universally agreed definition of ACAD, one that maps out the pathological stages and, importantly, links those stages to prognosis, to survival.
To know what finding, say, mild plaque actually means for someone's future risk.
Precisely. We need that clear framework. And it also means reevaluating terms like primary and secondary prevention. Well, those terms usually relate to whether someone is at a clinical event, like a heart attack. But if we detect plaque with imaging in someone who feels fine, where do they fit? Are they primary prevention? Secondary. It gets blurry. We need language that reflects the presence and extent of the underlying disease.
Makes sense. Okay, let's briefly touch on the how. How does this plaque actually form? What are the mechanisms?
It's complex, involving several steps. It often starts with the endothelium, the inner lining of the artery, getting damaged or dysfunctional.
Like the artery's Teflon coating wearing off.
Sort of, yeah.
Yeah.
That makes it easier for LDL cholesterol, the bad cholesterol, to get into the artery wall.
Okay.
Then the immune system reacts. Inflammatory cells, like macrophages, come in to clean up the cholesterol, but they get overloaded and turn into foam cells.
Foam cells, that sounds bubbly.
Yeah, they're a hallmark of early plaque. Then smooth muscle cells in the artery wall multiply. Things get more complex. A fibrous cap can form over a lipid core.
And that cap is key.
Very key. A thin, fragile cap over a large lipid core makes a plaque vulnerable to rupture. A thick, stable cap is less risky.
And all this is driven by risk factors.
Driven and accelerated, yes. The traditional ones, high cholesterol, high blood pressure, smoking, diabetes, obesity, are major players. But the Commission also stresses newer factors. Pregnancy complications, air pollution, stress, poor sleep. The gut microbiome, social factors. It's a wide net.
Right. Let's look at the global picture again. The burden of ACAD. We know it's huge.
It's the main driver of cardiovascular disease, which is still the world's #1 killer. And while we don't have perfect ACAD-specific data globally yet, data on ischemic heart disease shows a worrying rise in prevalence between 1990 and 2019.
Even in high-income countries where death rates have fallen, the number of people living with the disease hasn't really dropped.
Exactly. It's plateaued. We've made gains, like reducing smoking, but those have been canceled out by rises in obesity, diabetes, high cholesterol, maybe environmental factors too.
And the impact in lower-income countries is particularly tough, hitting younger people.
Yes, often striking people in their peak productive years. That has devastating economic consequences on top of the human cost. And projections suggest the global ACAD death rate could double by 2050 if these risk factor trends continue.
Doubling. Wow. And part of the problem is how we even track this. The disease codes.
Right. The current ICD-10 system mostly codes for ischemic heart disease, the late stage. ICD-11 is a bit better, allowing coding for coronary atherosclerosis itself.
But the Commission wants more.
They want coding systems that mandate reporting atherosclerosis before ischemia develops, and that clearly separate atherosclerotic causes from other causes of heart issues. Better data is crucial for tracking progress and targeting interventions.
Okay, let's dive into those risk factors in a bit more detail. We know atherosclerosis starts young.
Incredibly young,
Yeah.
potentially even in the first decade of life.
So the risk categories: behavioral, metabolic, environmental, genetic.
All play a role. And there's ongoing research into new or less understood factors, especially in diverse populations globally. Early screening for risk factors, even in childhood, becomes really important in this ACAD model.
What about aging itself?
Well, age is partly just a measure of how long you've been exposed to risk factors, but global aging populations definitely amplify the problem.
And genetics, beyond just family history.
It's usually polygenic. Many genes involved. We need more genetic studies in diverse groups. Family history is useful, but not a perfect predictor on its own.
Smoking, still a big one.
Huge. Initiates and accelerates ACAD. Global rates are falling overall, but not everywhere, and vaping is a new concern.
Obesity seems like a relentless problem.
Driven by diet and inactivity, leading to a cascade of issues: bad cholesterol, insulin resistance, high blood pressure, inflammation. And BMI isn't the whole story. Visceral fat, the fat around organs, seems particularly harmful.
Hypertension, high blood pressure.
Probably the single biggest risk factor for death and disability globally. And control rates are shockingly poor worldwide.
Then there's the whole metabolic cluster. Insulin resistance, high blood sugar, diabetes, fatty liver disease.
All increasing, all damaging blood vessels directly and indirectly.
Dyslipidemia, cholesterol issues. LDL is the main target.
LDL is central, causing endothelial dysfunction, driving plaque formation. Statins target LDL effectively. But we also need to consider other lipids like lipoprotein, or LP.
LPA. What's special about that?
It's largely genetically determined, not really lowered by statins, and it's increasingly recognized as an independent risk factor. Needs specific approaches.
What about chronic kidney disease, CKD?
Major independent risk factor. It's a two-way street with ACAD involving inflammation, mineral metabolism issues, oxidative stress, complex relationship.
And inflammation itself.
Chronic low-grade inflammation is a key driver. We can measure markers like CRP or IL-6. Imaging fat around the arteries might also reflect inflammation. It's a hot area for research and potential therapies.
Any others we should quickly mention? Homocysteine, microbiome.
Homocysteine's role is debated, maybe more relevant in some populations. The gut microbiome's influence via metabolites like TMAO is emerging, but research is still early, mostly in high-income countries.
And the lifestyle factors. Physical activity, diet, stress, sleep.
All crucial. Activity helps endothelial function, inflammation, lipids. Diet is fundamental. Mediterranean is well studied, sodium reduction important, stress links via hormones and behavior. Poor sleep, especially sleep apnea, drives inflammation and sympathetic activation.
Wow, it's a long list. Even things like surviving cancer, socioeconomic status, pollution.
Yes, cancer survivors have higher risk. Socioeconomic factors impact access, education, exposure, pollution, climate change, all have cardiovascular effects. It's incredibly interconnected.
Okay, given all that, let's talk prevention strategies. The Commission sees ACAD as largely preventable.
Acquired and preventable, yes. The ideal is primordial prevention, stopping risk factors from developing in the first place.
Which means starting really early, childhood, adolescence.
Absolutely. And while interventions give bigger absolute risk reduction in high-risk people later, the lifetime benefit of upstream early prevention is massive. Even prenatal exposures matter.
Prenatal, like what?
The maternal factors during pregnancy, gestational diabetes, hypertension, smoking, high cholesterol can impact the offspring's long-term ACAD risk.
How good are our current tools for predicting risk, those 10-year risk scores?
They have limitations. Often less accurate in diverse populations, focus on short-term risk, don't always include newer factors. AI and machine learning might help by integrating more data.
And genetic risk scores.
Polygenic risk scores show promise for identifying risk earlier and targeting prevention more precisely, but again, need validation in diverse groups.
So for primary prevention, stopping that first event, what works?
Implementing what we know works better, getting blood pressure and glucose to target, reducing smoking, treating high cholesterol with statins, they're proven and often cost-effective.
Statins are pretty well established now.
Yes, strong evidence, even for moderate-risk individuals. Aspirin for primary prevention is less clear-cut now. Benefits often don't outweigh bleeding risks for many.
Lifestyle is still foundational, though.
Absolutely. Diet, exercise, population-level policies help too, like tobacco taxes. Addressing obesity is huge lifestyle. Newer drugs like GLP-1 agonists are showing promise, sometimes bariatric surgery.
What about specific conditions like familial hypercholesterolemia, FH?
That needs aggressive early treatment. Cascade screening in families helps find cases. Newer therapies like PCSK9 inhibitors or even potential vaccines are important here.
And tackling those newer lipid targets like LPA.
Active research area. Specific drugs targeting LPA are in development. Anti-inflammatory drugs like colchicine show some benefit, but have side effects like infection risk. We need better ways to target inflammation.
We also need to make sure prevention reaches everyone equally, women, diverse groups.
Big issue. Historical underrepresentation in trials, differences in presentation, needs specific attention, and patient adherence is key long-term.
How do we improve adherence? Sticking with meds and lifestyle.
Things like polypills, combining multiple meds, long-acting injections, mobile health tech, reminders, support systems. Cardiac rehab after an event is also vital secondary prevention.
And screening, should we be doing more imaging like CCTA to find early ACAD?
That's the million-dollar question. We need to reassess screening to detect ACAD earlier, maybe with imaging or biomarkers. But we have to balance benefits against costs, radiation exposure, potential for overtreatment. It's complex.
Okay, moving to diagnosis. If we suspect ACAD, how do we confirm it and assess risk?
The ideal strategy links diagnosis directly to effective prevention and treatment. And it needs to be cost-effective and scalable globally to avoid widening health gaps.
AI might help here, getting results faster.
Potentially, yes. Especially in acute situations like heart attacks, getting diagnosis and reperfusion therapy quicker. But for stable patients, the traditional stress tests, they're looking for ischemia, right?
Sure, late stage.
Exactly. They don't directly detect the atheroma itself, especially non-obstructive plaque. That's where CCTA comes in again. Or even invasive imaging inside the artery during a catheterization, like IVUS or OCT.
IVUS and OCT.
Intravascular ultrasound and optical coherence tomography. They give incredibly detailed pictures of the plaque structure, identifying high-risk features.
Those are more specialized, invasive.
Yes, CCTA involves radiation and contrast dye. IVUS OCT require an invasive procedure. So, they have limitations regarding cost, availability, and risks. We need better non-invasive ways to assess plaque vulnerability.
Let's talk therapeutics. If ACAD is diagnosed, what are the treatment goals and options?
Historically, it's been about reducing future events and improving survival, plus relieving symptoms and improving quality of life.
Still the goals.
Yes, but the Commission adds 3 aims for future progress. Better implementation of therapies we know work but are underused, more intensive targeting of the atheroma itself, and making treatments globally applicable.
Okay, let's break down the treatments. Pharmacological first drugs.
Lipid lowering is foundational. Statins, ezetimibe, bempedoic acid, PCSK9 inhibitors all lower LDL cholesterol effectively.
But challenges remain.
Huge challenges in implementation, public trust issues, perceived side effects, the nocebo effect, and long-term adherence. Plus, ongoing questions. How low should LDL go? How early should we start?
Blood pressure drugs.
Very effective at reducing events, but again, implementation gaps. Are targets low enough, especially after a heart attack? Still debated.
Antiplatelets, aspirin, clopidogrel.
Proven benefit in secondary prevention after an event. Role in primary prevention is shrinking. We might need new trials for residual risk after standard treatment.
What about the newer diabetes drugs? GLP-1s, SGLT2 inhibitors?
They've shown remarkable cardiovascular benefits, reducing risk beyond just lowering glucose, especially in people with diabetes or established ACAD. But long-term adherence, cost, and how they fit with other therapies is still being worked out.
And anti-inflammatory drugs, colchicine, canakinumab.
Show incremental benefit in specific trials, but often increase infection risk. We probably need more targeted approaches, finding which patients or which plaques will benefit most. Maybe using imaging of inflammation.
Okay, what about surgical or device interventions? Stents, bypass.
This is where things get really debated, especially for stable coronary disease. Landmark trials like ischemia showed that for many stable patients, revascularization on top of optimal medical therapy didn't reduce death or future heart attacks compared to meds alone.
So meds first for stable disease?
Generally, yes.
Mm-hmm.
Though we need more research in specific high-risk groups, older patients, kidney disease, heart failure.
What about symptoms? Don't procedures help angina?
They can, but the evidence is complicated by the fact that many trials weren't blinded. There's a significant placebo effect with procedures. The Orbita trial famously showed stents weren't better than a sham procedure for improving exercise time in stable angina patients on good medical therapy.
Interesting. What about this idea of targeting specific vulnerable plaques?
It's an attractive concept. Find the risky plaque before it ruptures and stabilize it, maybe with a special stent. But reliably identifying those plaques non-invasively and proving intervention helps is still a major challenge.
So overall, for therapeutics, personalization is key.
Absolutely. Identifying who benefits most from which therapy. We also need better ways to measure quality of life using patient-reported outcomes, maybe via digital tech. And we need to reevaluate older drugs, like beta blockers after MI. Do current patients still need them long-term? But funding those studies is hard.
And new preventive drugs face a high bar.
Very high. Because current therapies like statins and blood pressure meds are already quite effective and often generic cheap. New drugs need to show significant added value.
Shifting gears slightly, the Commission emphasizes inclusion in research.
Foundational. Research needs to reflect the real-world women, men, diverse ethnicities, socioeconomic backgrounds. Historically, trials have often skewed towards white men.
How do we fix that?
Need deliberate strategies to overcome enrollment barriers, ensure trial populations match the populations who actually have the disease.
And implementation, making sure effective strategies actually reach patients.
Critical. We need to compare low-cost, established treatments with newer, expensive ones. Cost effectiveness matters. AI might help here too.
AI again? How?
Automated diagnoses, mining electronic health records to find high-risk patients, tracking symptoms, maybe even making healthcare workers more efficient. But it needs rigorous testing. And the focus should be on low-cost, high-impact AI solutions.
This all implies big changes for healthcare systems, doesn't it? Moving from treating ischemia to preventing atherosclerosis.
Huge changes. Current systems, training, funding are often biased towards late-stage, hospital-based care. We fail to implement proven preventive therapies effectively, and access is unequal.
So more community-based care, remote monitoring.
Yes, care needs to move closer to the patient. Needs strong health economic evaluations to make sure we're getting value for money. More comparative effectiveness research, better education, inclusive registries.
What about the workforce needed for this?
Effective ACAD prevention and care is personnel intensive. We need more investment in community and primary care teams focused on prevention, not just specialists dealing with crises.
But there are workforce pressures globally.
Definitely. Economic pressures, burnout. We need more primary prevention staff, maybe disrupt old office-based models, upskill community teams, use digital health, non-physician providers more effectively.
Like integrated community and specialist teams.
Exactly. And technology could help train people faster. We also need to address the brain drain skilled health workers moving from low to high-income countries.
Finally, health policy and public education. How important are they?
Hugely important. Population-wide policies on things like smoking, diet, exercise are often high-value interventions. We need sustained action on smoking, maybe more restrictions on vaping.
And public awareness needs to shift.
From just focusing on heart attack symptoms to understanding risk factors and the importance of early screening for atherosclerosis itself, we need to test these policies and education programs properly too, using real-world data.
Requires partnerships.
Government, professional societies, global organizations all working together. AI might even personalize public health messages based on individual risk profiles someday.
So wrapping this up, it's been a fascinating deep dive. The key takeaway seems to be this fundamental shift from just treating late-stage blockages, the ischemia, to focusing on the underlying disease, the atheroma, across the entire lifespan.
Exactly. Recognizing ACAD as a lifelong process and prioritizing early detection and prevention,
Right.
implementing what we know works, developing new strategies, and ensuring equitable access globally.
The potential impact, as the Commission lays out, is enormous, preventing millions of deaths and improving cardiovascular health worldwide.
It really offers a roadmap for a healthier future if we can make these changes happen.
So, a final thought for you, our listener. How does reframing heart disease as this long-term process, starting potentially very early, change how you think about your own health or conversations with your doctor? Maybe it shifts the focus from worrying about an event to proactively managing the underlying process.
Understanding this science and the evolving approach is really key. We hope this discussion has shed light on this important shift and encourages you to stay informed.
Absolutely. Thanks for joining us for this deep dive. Until next time, stay curious.